Guidelines recommend prescribing proton pump inhibitors or other gastroprotective agents to elderly patients who are taking non-steroidal anti-inflammatory drugs. However, the guidelines do not agree on when this therapy should start. Some say 65, but some say 70 or even 75 years of age. Also, recent concerns have been raised about side effects from the PPIs themselves. We wanted to investigate the effectiveness of gastroprotection in relation to age. The standard way to determine this is to look at evidence from clinical trials. However, we know that elderly patients are often excluded from clinical trials. Indeed, elderly patients did appear to be underrepresented in the trials included in the 2009 Cochrane Review of Gastroprotection for Non-Steroidal Anti-Inflammatory Drugs. However, observational studies can offer a better real-world picture of patients, including elderly patients with multiple medications and comorbidities. So we decided to take a look at observational studies to try to answer the question of at what age gastroprotection should be started and whether the benefits outweigh the risks. We performed a systematic review of the literature, looking for both studies reporting the rate of co-prescription of gastroprotective agents with NSAIDs in elderly patients, and observational studies of the efficacy of these agents in preventing gastrointestinal events, with the intention of pooling the data for a meta-analysis and using the rate of co-prescription to determine what the efficacy might be if more patients were treated. However, the studies have to be fairly similar to be combined in a meta-analysis. You can use meta-regression to correct for differences between studies, but only if you have many studies, about 10 per factor you're correcting. Nearly every study measured a different outcome, from self-reported gastrointestinal upset to hospitalization with a serious upper GI ulcer. Measurement of exposure to non-steroidal anti-inflammatories, short-term versus chronic, and most importantly, co-prescription were also different. This definition is critical because it determines whether the patient was protected or not, but also because it tells us something about the patient's other risk factors. Patients often take proton pump inhibitors for reflux or other diseases that are themselves risk factors for gastrointestinal events, which changes their prior risk and therefore the apparent efficacy of treatment. No studies measured side effects from the gastroprotective agents themselves, and the two cost-effectiveness studies reached opposing conclusions. One concluded that protection cuts costs by about 50%, and the other concluded that it costs about 5,000 euros or 6,000 US dollars per ulcer complication prevented. Unfortunately, this means that the only firm conclusion we can draw about the relationship between age and gastroprotection is that we need additional evidence. However, all of the included studies do report a positive effect after adjustment for other risk factors, so it appears that gastroprotection is generally effective in older patients. We can also say that it is unlikely that we will have sufficient observational studies or clinical trials in the near future to simply adjust for differences between studies. Future researchers will have to actively work to make their results more comparable to other studies. This can be accomplished by reporting multiple clinical outcomes, testing the sensitivity of definitions of exposure and co-prescription, measuring side effects, and reporting results by 5-year age category. This will allow us to answer questions about at what age gastroprotection for non-steroidal anti-inflammatory drugs should be started, and perhaps more importantly, if there is an age beyond which both medications should be stopped.